Okay, once again, for those of you just joining us, happy Friday Eve. My name is Leanne Foster, and I am a provider outreach and education specialist here at WPS. And again, for those just joining us, I do want to thank you all for taking the time to join us today. We'll go ahead and get started. So I want to welcome everybody to part one of our two-part back to school series on prolonged care. So part two is going to be tomorrow, and it is the pop quiz for prolonged care denials and how to pass. Part one, which is today, we're going to focus on the policy and how to bill for prolonged care codes. We will have time for some questions and answers, but tomorrow will be a Q&A session that's interactive. This is something we're trying. We're trying these two-part series for a couple of topics, and you'll see some more as we get into the back-to-school season. We're hoping that these sessions will be effective for you and helpful to you, and we want to ensure that you have ample opportunities not only to get the material that we have to present to you, but also an opportunity for you to apply your knowledge, because remember I said part two is an interactive session. And of course, we want to make sure that we're answering all of your questions on prolonged care. So if you have not registered for part two of this two-part series, I would like to encourage you to register for that. Registration is still open, and I've asked Ashley to put that in the chat. So again, this is part one. So we're going to go ahead and start with just a little bit of housekeeping. So materials for today's session are available. If you've already downloaded them, you're all set. If you haven't and would like to, those are available on our training center. They are not required for attending today's session, but you may like them for following along or note-taking purposes. So once you get into the training center, which Ashley is placing into the chat, you will see the title for today's session and a link that says training material. When you click on that link, it's going to allow you to download the PowerPoint slide deck for today's session so that you have that. Also, I mentioned we are recording this session, and it will be available for 60 to 90 days on our Encore presentations page without accessing our YouTube channel, because we recognize that not everybody can go to YouTube while they're at work or on their work machines. So that's going to be available for 60 to 90 days through a player without needing to access that. It will be available after 90 days as long as the information is still accurate and relevant. And that'll be there for you in case you want to see something again, or perhaps this information will be helpful to someone who couldn't attend and you want to share that. Questions today, like I said, this is a two-part series. Tomorrow is going to be focused on questions and answers and denials and rejections specific to prolonged codes. However, we are going to be answering questions as we can today during this session. And some of you did provide pre-submitted questions that I want to thank you in advance for. That was used to adjust the material for today. If you have questions today, go ahead and send those questions in the chat. Ashley is going to be monitoring those, and I will be checking in with her on those. If we have more questions than there's time for today, a couple of things. As I said, tomorrow's a question and answer session, so I encourage you to come back. But we'll also send a follow-up document for any questions that we do not have time to respond to today, and we will send that out to all attendees. Also, after the session today, we are hoping that you'll take some time to provide us with a little bit of feedback. Your opinion matters, and that feedback is used to select our educational events, improve our educational events, and maintain those that you're finding useful. So I want to thank you in advance for taking a little bit of time. And as I said, this is a new approach that we're trying with our two-part series, breaking this up into the base guidelines and then also a question and answer session. So we'd really like to hear from you on whether this is working for you or if there's something we could do to improve that. So you'll have that opportunity towards the end of the session. This is our standard disclaimer. Material is created based off of current CMS rules and regulations, and so it is accurate and current as of today. If you've worked with Medicare for any period of time, you are well aware of the fact that Medicare rules and regulations change, and they change often. So I just want to encourage you to ensure that you are still monitoring official CMS communications, which does include the WPS website, just to make sure you're following those current rules and regulations. Also, CMS does prohibit the recording, screenshotting, or photographing of this session for profit-making purposes. And as I mentioned moments ago, we are recording this session, so you will have that recording available and there's no need to record it. Just a couple of quick copyright notices before we get started with our material. This first one is the AMA CPT copyright notice. We will be sharing some CPT codes with you, and this is just the copyright notice acknowledging that the AMA is responsible for those descriptions and not CMS or WPS. Also, the American Hospital Association has a copyright notice. We will also be sharing with you codes that may be billed using a UB04 or 837I transaction. And the same thing here, it's just letting you know that the American Hospital Association does own those codes and those descriptions. All right, that brings us to our agenda and objectives for today. As I stated, this is the first in a two-part series. So today we're going to focus on providing you with an understanding of prolonged care codes and how to bill claims using them. Prolonged care codes have been included in some of our other evaluation and management sessions, but we wanted to split it out and talk through those codes. And we did receive quite a few questions just looking for an overall instruction and policy on when they can bill those codes. It can be a little confusing. There are different codes for different types of services. So what we're going to do today is we are going to provide a prolonged care overview to help you better understand when you may be able to use those. And then we're also going to go through prolonged care coding, and this is going to include some resources that CMS has set for those time thresholds to help you when you're billing prolonged care codes. I will be using a few acronyms today. I have included them here in case you'd find those helpful, though I'm not going to go through those, but they are here for you if you'd like those. Okay, so that brings me to our overview. So let's get started. So first and foremost, as with any other evaluation and management code, medical necessity is the first determinant of coverage for these services. So in order to bill prolonged care services, the services provided as part of that prolonged care do need to meet medical necessity for the patient. Medical necessity is defined in the Social Security Act of 1935 in Section 1862. Again, the services must be reasonable and necessary to treat an illness or injury or to improve the functioning of a malformed body member. So this is going to all be based on your documentation. Things that you're going to want to make sure that it answers is, what are you doing for the patient? Is it reasonable? That needs to be in that documentation. And we're going to talk about documentation for prolonged care codes later on in the session, but this is in general for establishing that medical necessity. And the other thing you want to ask is, why does your patient need the service that you're providing for this encounter? If it's not something that's medically necessary, why is it happening? When MACs are doing their medical reviews, they are looking at that medical necessity. That's the very first thing that they're looking for. They're also looking to make sure that it's not something that's statutorily excluded. So those are things that you want to keep in mind when you're providing these services. And again, that documentation has to clearly show the medical necessity for the services rendered, and that could be different for each patient. So CMS began reimbursing prolonged care codes beginning in January 1 of 2023, and it was part of the final rule. The intent was to ensure that providers are being compensated for additional time and effort that's being dedicated to a patient's care that is considered to be above and beyond or more than what is typical for patient care. There are going to be circumstances that may require the provider to spend more time with a patient. It could be based on the complexity of their conditions and a comorbidities, just the individual patient's needs. So these codes are going to allow providers to bill for that additional time spent, and these are add-on codes. So they are used alongside a primary E&M code. And you'll hear myself, and tomorrow you'll hear Ashley say this as well, but they these codes do need to be billed on the same claim as that add-on code. We're going to be talking about some G codes today. These codes are not going to be used if you're using medical decision making to determine your level of service. These are time-based codes, and so prolonged care only applies if you're using time to determine that level of service. So medical decision making is based off of the problems that are addressed, the data that is used and analyzed during that encounter, and then the assessment of risk of the care plan to that patient, which could include procedures that were performed, treatment to the patient, or that care plan. What are the future care plans? So you do need to make sure that you are using time if you're using prolonged care services. Now, with most services, most E&M services, you are going to have the option of selecting your level of service based off of medical decision making or time. Use the one that's most advantageous to you. You may have to do some type of a comparison in your office. Maybe MDM makes the most sense. Maybe time makes the most sense. It's not going to be across the board. It's not going to be the same every patient. So it's something that you need to decide. But again, if you're using time, you can use time-based prolonged care codes. Now, the time for this is going to include both face-to-face and non-face-to-face time, and we're going to talk about what's included in the non-face-to-face time in a moment. But face-to-face time is going to be that encounter. It's going to be the time that you've spent with that patient. You want to count that. You'll hear me say this as well. We're not looking for providers to stopwatch themselves, but a range is not something that's going to be your best practice. Your documentation does need to support the amount of time that is being billed on that claim. One other item that I do want to point out is that you're going to see places where CMS guidelines and CPT guidelines do not align as far as time thresholds or codes billed. You do need to ensure that you are following CMS guidelines when you're billing prolonged codes to Medicare. For instance, CPT has different codes. They list 99417 as a code for outpatient E&M services and 99418 for inpatient observation. Those are not payable codes by Medicare. You do need to use the specific G codes that we're going to talk about today when you're billing prolonged care for Medicare. So non-face-to-face time, I do want to talk about qualifying activities. So these are the activities for non-face-to-face time that can count towards the total time for your visit. If you're not counting this time, you might be missing out on some reimbursement. Again, you can select for medical decision making or time for most codes. The exceptions would be for emergency room care and critical care services, because those do need to be done based off of medical decision making. But you want to again look at which method is most advantageous for you. So the types of services that are included for non-face-to-face time and can count towards the total time of the visit would include preparing to see your patient. Maybe you are looking at data. There are going to be some examples that I give today where you're actually maybe coordinating their care plan. Maybe before that visit, you want to have some options ready for them. And that time is part of your patient care and it should be counted. Another thing that you could use is obtaining or reviewing a separately attained history. So this could be a conversation with a family member, a caregiver, but that time does count. Performing the exam, that is generally going to be face-to-face, but if you're charting that particular exam, that counts as time. You could include counseling or education of a patient or family member or caregiver. So maybe there's therapy, or maybe there's some guidelines for what has to happen at home. Maybe you're counseling them on some equipment. that they need to obtain or some services that they need to engage, but you're providing that counseling, this is something that can be counted. If you're ordering medications or tests or procedures and you're setting that up and you're coordinating that care, as long as it is done by the practitioner, if it's the provider or other qualified health practitioner, as long as it's done by the practitioner and not ancillary staff, that can be counted towards the total time spent with that patient. If you're doing any type of referral setup or you're communicating with their care team, there could be other providers or other practitioners that you're communicating with. That time, as long as it's part of this patient's care plan, that is something that can be counted. Also, you may have instances where you need to coordinate care with a community agency. That is outside of your office. That is maybe something that you're doing before and after that encounter. But that is, again, time that can be counted as the total time for the visit and could qualify for billing as prolonged care if the time thresholds are met. Now, there are some things, there's quite a list of things that you can count. There are some things that you cannot count. So when you're calculating time, you're not going to want to count time for any services that are separately reported. The last slide I mentioned an interpretation of a test result. If it's not being separately reported and billed. So if that professional fee is being billed separately, it's built into that. You don't want to count that twice. We're also not going to count, you're not going to count time that's travel time to the visit. Okay, so that is not considered part of that visit. You're not preparing for that visit in any way. It's not part of the patient care. Any teaching that is general and not specific to the management for that individual. So it does need to be something that that education or that counseling for the caregivers, we mentioned that. It does need to be specific to that patient's plan of care, not something just in general. And then if you have a practitioner and a patient that are engaging in another conversation, I think we've all experienced this. We'll go in, we have our primary care provider or a specialist that we see often, and you start to build that rapport and you start to build that relationship. And sometimes the conversations can, go into something that's a little bit more personal. My husband is a chef, and so most of my practitioners know that from some conversation, and they'll usually ask how that's going or what his favorite food to cook is or what my favorite one is to eat of what he cooks. Those are certainly conversations that are not going to count in that time, because that's, again, just kind of building that rapport. So you need to make sure that the time is for the specific management of that patient that you're counting. So for prolonged care, I've said this, but you do need to meet certain time thresholds. And again, this is where CMS and CPT do not necessarily align on all of the codes and what those thresholds are. I'm going to show you some resources here in a minute that are going to help with that, though. So you do need to meet the time thresholds, and it means that you need to exceed the time allotted for the highest level of code. So for example, for an office visit, 99205 is the highest level of code for a new patient, and it indicates that 60 minutes must be met or exceeded. To start thinking about prolonged care codes, you need to exceed that, but you also need to meet the CMS time thresholds before you can bill, and we'll show you that. 99215 is another example. That is the highest level for an established patient, and it indicates 40 minutes must be met or exceeded. And so what I'm saying here, I'll use 99215 as the example. You're not going to bill for prolonged codes unless you're also billing for 99215. 99214 is not the highest level of code for an established patient, so prolonged care codes would not be eligible for those lower levels. You need to hit the highest level for that category. Now, as I said, CMS has outlined the time thresholds that must be met before prolonged care can be billed. And these are in the Medicare Claims Processing Manual, Chapter 12, and they're in Section 30.6.15.1, and they're also in the Evaluation and Management Services Guide. So I'm going to go ahead and take you out to CMS website. Now, there's a couple of ways that you can get to the claims processing manual. You can go through manual and go through regulations and guidance. I like to either search, or in this case for a manual, I go down to the top resources. Your manuals, forms, and transmittals will always be here. And you're looking at the internet-only manuals. As you can see, I'm out here a lot. And here you're looking for that Medicare Claims Processing Manual, which is publication 100-4. And I am including a link for this at the end in the resources section of your presentation, so you don't have to worry about jotting this down. You will have that. And then we're looking at Chapter 12 for physicians, non-physician practitioners. Now you can scroll through here. Again, I like to search, so I'm going to go ahead and search for prolonged. And we get to 30.6.15.1. And what you're going to see here, and it will include information for all of the codes that I'm going to go through today, but what you're going to see are subsections that include charts. These are super useful charts that show examples, or they show the thresholds for billing prolonged codes to Medicare. So for instance, I'm going with the 99215, but 205 is here as well. 99215 is 40 to 54 minutes. You are still just going to bill the 99215. Then you need to meet 15 minutes in order to bill for a prolonged code. So here it's showing that you can bill the G2212, which we're going to get to in a minute, once you hit 69 minutes. And this brings me to a pre-submitted question that we had. We did get a question about if the provider has provided 66 minutes of patient care, can I bill that G2212? And the answer is no, because you need to meet the CMS thresholds that are outlined in the claims processing manual. And this is one where CPT and CMS do not align, so you need to be careful and make sure that you're referencing the CMS available information. The other place, and this is also super handy, is in the evaluation and management booklet, which I've also included a link for today, does have a section on prolonged care. And what you'll see is that those same charts are here so that you have those for reference. And I did just mention this, but I want to just reiterate the fact that you can bill a prolonged care code in 15-minute increments. You must have the full 15 minutes in order to bill for a unit. You can bill for multiple units if you're meeting multiple 15-minute thresholds. So for instance, if you provided 10 minutes of prolonged care, that is not a unit. You have to hit 15. If you provided 20 minutes of prolonged care, you can bill for one unit. That's a full 15. There are 5 additional minutes, but you need to meet the next amount of 15 before you can bill for 2 units. So if you're providing the 30 minutes of prolonged care above CMS's threshold, you can bill for 2 units. And I hope that makes sense, but again, we're going to go through some examples that should help solidify that a little bit. The other thing I want to point out, and you'll see this as we go through our billing requirements examples, that the time thresholds are going to vary based on different types of care. So we're going to talk about outpatient services, we're going to talk about inpatient and observation services. We'll also run through nursing facilities and home visits so that you have that information. So here we're going to go into those billing requirements. I've also included screenshots of those charts in your training materials, so you have those for reference. You'll note that they're all the same and they're all coming from those locations that we just went to. So for office and other outpatient visits, the prolonged care that you're going to use is G2212. This is the one we see the most questions on, and the ones that we were including some information in our material for today earlier, as you saw. So you must use time to choose your level of service. One question, pre-submitted question that we got was, what if the patient has stable chronic conditions and are only seen once a year? Should this code be used? And the answer is, it's not based on the patient's condition. G2211 and all of the prolonged care codes, they're based on level of care. So it's not based on that they have a chronic condition. It's based on how much time was spent with the patient. And remember, for office and outpatient services, you can choose to select your service level based off of MDM or time. Again, whichever is most advantageous to you, and it depends on the patient. Perhaps a patient with a chronic condition seen once a year, it's stable, you're not spending a ton of time with that patient. Maybe they come back the next year and the condition has exacerbated and you're spending an extended period of time, and maybe MDM doesn't make sense. Maybe time does, and maybe you spent enough time for both face-to-face and non-face-to-face that a prolonged care code would apply. So you really do have to look at that visit. It's not based on just having that chronic condition. But that's an excellent question. Thank you. So for outpatient and office and other outpatient services, the time that you're counting is going to need to be on the same date of service. I call that out because as we get into some of the others, you are going to be able to use time that's not necessarily on the same date of service. And we're not expecting a stopwatch. If you're using non-face-to-face time, don't leave money on the table. Make sure that you're counting that if it happened on that same date of service. To use G2211, you have to exceed the time allowed for the highest level of codes, and I've included those, which is 99205 and 99215. And again, you must meet that full 15 minutes. The threshold for 99205, CPT indicates that that threshold is going to be the 60 minutes, and they will say that you can start billing for services 15 minutes after that, which would be the 75. Just remember that the threshold for 99205 to start billing for long care for Medicare is 89 minutes. So you have to hit that 89-minute threshold. For 215, CPT will say at 55 minutes you can bill for prolonged care codes. However, the CMS threshold to begin billing is 69 minutes. So make sure you're referencing those charts. There is an additional consideration for G2212. You can use G2212 for cognitive assessment and care planning, which is going to be a comprehensive assessment and care planning for patients with cognitive impairment. So think dementia. So this will include a cognitive focused evaluation. So it's not going to be just a regular evaluation. It's going to be cognitive focused. It's going to include functional assessment of their ability to perform activities of daily living. It's going to include the use of a standard instrument. So there are instruments, or I want to say checklists or questionnaires, but kind of. There are going to be a couple of options that are available out there for assessing that cognition. And then we're also looking for a medical review, and then there's going to be some advanced care planning and assessment of caregiver needs. So you can use G2211 for that, again, exceeding highest level of code for time and that full 15 minutes. But here's where things get a little bit different. It doesn't necessarily have to just be face-to-face and non-face-to-face time on that date of service. You can include time that is 3 days before. So this could include preparing for that visit. So maybe you're reviewing test results that they've had. Maybe you're making arrangements for their care so that you have that plan in place when they come in for their visit. As long as it's related to the cognitive assessment and care planning for them, that time that was spent doing that can be counted up to 3 days before. As with any other prolonged care code, you can use obviously the time for the date of service, both face-to-face and non-face-to-face. Obviously, this is likely where that face-to-face encounter is happening. And then you can also count time that is spent on their care plan for up to 7 days after the encounter. And again, this is going to include things, maybe that you're reviewing some tests that you schedule after that face-to-face encounter. Maybe it's communications with other practitioners. You're making arrangements. Maybe you're having to adjust their medications. Maybe you prescribe them with something they're not reacting well a couple of days in. Maybe you have to adjust some things. Again, it can be unique to the patient. But this is an exception to what we just talked about for G2211. For all other office and outpatient services, it does need to be face-to-face and non-face-to-face time that happened on the date of service. There, for cognitive assessment and care planning, we do allow the window, which is, when you look at it, it's about a 10-day window. Prolonged care codes may also be billed for inpatient and observation care services. They do use code G0316, and I do want to call out again that prolonged care code is not going to apply to emergency department visits or critical care services. Those are simply too complex of care that to be allowed to be billed by time. It's hard to track. Oftentimes the providers are seeing multiple patients. So those are two types of services that you do have to use MDM. And when you're using that medical decision making, you cannot use prolonged care codes, again, because they're time-based. You do also have to meet or exceed the highest level of time for the codes. So we're talking about 99223, and that's for that initial visit, and that's going to be for that's up to 75 minutes, and then 99233, which is a subsequent visit, and that's going to be up to 50 visits. Now you will see the time thresholds here are a little bit higher. So for your initial inpatient observation visit, it is 90 minutes before you can start considering billing for prolonged care codes, and subsequent is 65. So there is that full time there. You will only count the time for the same date of service. There is one exception, though. If you have a situation where the patient is admitted and discharged on the same day, that is a time where you could count the time for up to 3 days after that discharge. So again, just depends on the patient. Just make sure that you're referencing these charts. This is also available, and I'm just going to go out there so you can see that. This is the evaluation and management resource. And there is one table. I broke it up in the presentation just to make it a little bit easier for you to read, but this is going to be out there in this particular table, as well as out in the claims processing manual. So these are going to be really good resources. These are going to be your guide when you're billing for Medicare. And again, CMS and the CPT are not aligning here, or in all circumstances. So just be careful of that. Next, we're going to talk about nursing facility visits. For nursing facility visits, you are using code G0317 for any prolonged care that you may have, that you may bill. Here again, you can choose to use MDM or time for these services. You do need to look to see which makes the most sense for your patient, for your office. It's not going to be across the board for the office, and I don't think I mentioned that before. It could be individualized based on that patient, and we want to make sure that providers are reimbursed for time that is spent that is above and beyond what is considered normal and customary time spent for patient care. So we're looking at billing G0317 when you are exceeding the highest level of time allowed for 99306, which is defined in CPT as 50 50 minutes, and the time threshold for that before you can bill a prolonged care code is going to be 95 minutes, as you can see here. And 993-110, that is 45 minutes, so you have to be above that, and the time threshold for that is going to be 85 minutes. But again, here you're going to be able to include time from a range of dates. It's not just the date of service. It can be the day before. Maybe you're preparing for them to come to that nursing facility, or maybe you're making those arrangements. The date of service, certainly, and then up to 3 days after. Next, we're going to talk about home visits. Oh, sorry, that did not flip like it was supposed to. There we go. So prolonged care for home visits is going to be G0318. And again, you're seeing a theme here. It must exceed the highest level of code. And so here for reference, I've added the 99345, which CPT defines as 75 minutes, and then 99350, which CPT defines as 60 minutes. And you'll see the time thresholds are higher than a full 15 minutes past that 75 and that 60 minutes. For the 99345, you do need to hit that 140-minute threshold, and 110 for the 99350. And remember, you can bill potentially multiple units of prolonged care code for every additional 15 minutes that you spend with that patient. Again, just needing to look at the time spent and make sure that that's documented and determine which is most advantageous for you. Which brings us to documentation. And we received a lot of questions regarding how to best document. This is a question that comes up in most of our webinars, because documentation, it's something that is not cut and dry. It's not going to be one size fits all. There are some guidelines, but it's going to be different based on what's happening with that patient. The one consistency is that it does need to support that level that is being billed. In CMS guidelines and documentation, they consistently emphasize that the documentation has to be accurate and complete. And as I said, it has to support the services that are billed. It has to support medical necessity. It has to show that the services were reasonable and necessary for that patient. It does need to include what services were provided and what happened during that encounter. Now, we're not looking for increased provider burden. We're not looking for a novel. It just has to be sufficient enough to support what happened. And in the instance of prolonged care, it does need to support why prolonged care was needed for that patient. And a lot of that will be supported by what occurred there and the documentation of that time. It should also include what is the plan for that patient moving forward. Are there non-face-to-face items that need to occur in order to implement that plan? So it just needs to be clear to a medical reviewer what happened, and that, yes, this is why we build this level of code. Anything that is unclear, anything that is maybe missing, is something that you want to make sure is tightened up, if you will. You want to make sure that it is clear to someone who's reviewing it. And this is our medical review staff that are going to be looking at that. So there's a couple of things that you want to think about with prolonged care code, and it's mainly going to be that time. You've got to clearly document that total of time spent with the patient. Again, not expecting there to be a stopwatch, but make sure you're not leaving money on the table and you're including both the face-to-face and the non-face-to-face time, because those activities that we listed in an earlier slide, those are activities that count as part of that patient care. Make sure that you're doing that. One thing you do want to stay away from, though, and we do see this, blanket statements where I spend between 60 and 100 minutes with the patient. That's not going to be a best practice. that is, it's not clear how much time. That's a wide range. Certainly I'm giving kind of an extra large range there for an example, but you do need to give us an actual amount of time that was spent. All right. Before I check in with Ashley on questions, I do want to point out a couple of resources, and we did go through these today. We did have the Evaluation and Management Services Guide, and again, I'm just going to go out there. So this is the Evaluation Management and Service Guide. It does have in the table of contents, you can jump straight to the prolonged care services, and it does outline those charts that are also in that Medicare claims processing manual. So you want to make sure that you're meeting those thresholds. And then, as I said, the claims processing manual, again, I search for prolonged codes. And it is 30.6.15.1, so that's the section, and it does include all of the same charts that Service Guide has. So you want to make sure that you're referencing this before you're billing for prolonged care codes. I can't stress this enough. CMS and CPT do not align, so make sure you are following CMS time thresholds. So with that, I am going to check in with Ashley to see if there are any questions in the chat.
Hi, Leanne. We did have a few questions come into the chat. The first question is, when billing the G2212, can you bill multiple units on one claim line, or should each G2212 be reported on a separate service line?
Excellent question. The important piece with billing these is that they come in on the claim with the primary E&M code. So certainly make sure you're not billing them on separate claims, but they do not need to be on separate lines. You can bill for multiple units of G2212 on one line. But again, you need to meet a full 15 minutes for every unit that's being billed. I gave that example of if you build 20 minutes, that's one unit of G2212. You'd have to hit 30 minutes before you can bill multiple, and then another unit for each one.
All right, can I answer your answer?
Excuse me?
Can I add to your answer on that?
Oh, certainly, Tom.
So for the line billing, also make sure you check the medically unlikely edits on the CMS website. And the reason that I'm recommending that is there is an edit in place for it. It is a public edit, and the G2212 allows 6 units. So if you were to need to bill a site, like, and I'm just making this up hypothetically, but if you were to need to bill 8 units, you could bill a second line, modify it with 2, 6 being the primary line that we know we're going to pay. You may not be able to get those paid without going through the appeals process, because this is a clinical data review. And anytime we have clinical data review, it has the possibility of making it go through the appeals process to get those paid. But I just wanted to add a little bit more in terms of the medically unlikely edits.
Thank you for that, Tom. Excellent point. Appreciate that. All right. Ashley, next question, please.
All right, the next question is, we are an RHC and receive our AIR or AIR for each visit. Are the prolonged care codes eligible for additional reimbursement in an RHC? And if yes, do we need to submit with a 25 modifier?
I'm going to have to take that one back, Tom, unless you know, but that AIR rate is a standard billing rate, and typically, I know with some of our other add-on codes, they're not eligible for additional reimbursement, but I do want to confirm that, so I will get back to you. I see that's coming in from Mickey. So Mickey, I will double check on that, and I will get you a final answer on that.
Yeah, I do think you need to check on it, but I will say that it's not listed as a separately payable code, which would lead me to indicate that it's not separately payable. But we all know how that goes, and you got to make sure you read through all the little details. I just know that as an initial, I know it's not separately. I know it's not listed as a separately payable code.
All right, Ashley, you want next question, please?
Sure. The next question is, can you use the G2212 and the complexity add-on code G2211 on the same visit?
The answer is yes. There are add-on codes, but they're for different things. So the G2211 is representative of the provider being that focal point of care and having that longitudinal relationship. So that's an add-on code for something different than the prolonged care. Prolonged care is for that extended time that's above and beyond what's typical for patient care. So it is something that can also be included.
All right, that was our last question in the chat.
All right, excellent questions, y'all. If you think of any, we are going to offer an opportunity for you to send some follow-up questions, but we'll go ahead and wrap up if there are no other questions for today. So we do want to make you aware of a customer service process change that happened on August 4th. To better serve our providers and streamline our call handling and make it more efficient, our contact center will accept only one MPI and P10 combination per phone call. And again, this started on August 1st. This change is being made to improve the efficiency and decrease call wait times because of what is involved with switching with those MPI and PTAN combinations. So if you need assistance for multiple combinations, please be sure that you're placing separate calls for each one. That's going to allow our teams to handle those calls more efficiently. Some other things that will improve your call time is going to be having your information ready, and this would include obviously that MPI and PTAN, the last 5 digits of your tax ID, and then for claims questions, we're also going to look for some information on the patient, their last name, first initial. We're going to need the date of service and any relevant billing information. Again, just having that ready helps them authenticate quickly and get to the information. The other thing is we do offer our Secure Net Access Portal, also known as SNAP. This is available 24/7. It is free, it's convenient, and it allows you to check a lot of things, including claim status. You can check on claim denials. You can also check your claims eligibility here. So it's something to consider if you've not already done so. We have held some events, and we do have some recordings of those events on our YouTube channel if you're new to that portal, and to help you get started with that. So in a few minutes, you are going to receive an email that's thanking you for attending. Don't delete this without reading this. It does contain a lot of information. It contains an option for taking our survey. It also contains contact hours or your certificate of achievement if you're attending today for any continuing education unit or continuing education credits. So you can submit this to your accreditation or certification body in order to get those CEUs. So if you didn't get it, one of two things happened. Either you attended by phone and I simply don't have a systematic way with which to count your attendance, or you had something go to your junk, your spam folder. The sender on this is WebEx Messenger, and if it's not added to your safe sender list, it can end up there. In either event, I have you covered. So what you will need to do, and Ashley will put a link to the education mailbox in the chat in a few minutes, you will send an email stating that you attended today. Please provide the phone number from which you attended, because that's how I'm going to check your attendance. Once I confirm that, I'll be able to send out that certificate. As I said, there is a further opportunity for follow-up questions if you have them. I will be accepting them for the next 7 days. So you can email to the education mailbox. Ashley's added a link. You're going to want to include the topic for today, which is study hall prolonged care codes. I've even made it easier for you. If you click on the link in the material, if you have that, that's going to open an email with that subject line already pre-populated. So go ahead and send those. That subject line is, again, going to let the individuals that monitor the mailbox know that, hey, this needs to get to Leanne and Ashley and Tom for a response. If you have claim-specific questions, you do need to contact customer service for those. Just keep that in mind. As I mentioned earlier, your feedback is super important to us. And as I mentioned, we are doing a slightly new format. Today, we covered prolonged care, we covered the basics, and we covered the billing guidelines. Tomorrow is our part 2, which is an interactive Q&A session for you. So if you have questions, bring them tomorrow. Also, if you'll be able to apply your knowledge through some activities that we have planned for tomorrow. So we'd like to know whether or not this is something that's working for you and if you'd like to see it in the future, or what can we tweak. So give me the good, the bad, what can I work on? What can we do to improve our education for you? What did you like? What do you want to make sure that we keep doing? And also, this is an opportunity for you to provide us with ideas on education that you'd like to see. Maybe there's something that we're not offering that you would like. Maybe you'd like something more specific. Throw that out here. It doesn't even need to be related to prolonged care. So again, I appreciate your time for taking that. And you're going to have a couple of options. One, Ashley just gave you a link. Click on that. It'll take you to that CMS Qualtrics survey. Also, as you leave the session today, you are going to get a redirect. It does look like what you see here on your slide. That is just telling you that it's taking you to the CMS Qualtrics software. You're leaving our webinar software. It's not spam. It's not malicious. It is not taking you anywhere that you don't want to go or dangerous. So keep that in mind. And your feedback is important, and we want to call out some things that we have done directly based on provider feedback from those attending our webinars. One, we added chapters to our YouTube. So if you're watching this electronically or any of our other videos electronically, instead of scrolling or scrubbing through a video to get to the point in the video you maybe want to see again or want to see for the first time if you're watching this in a recorded manner. For the first time, we have chapters. Those chapters go to key points that will help you navigate those videos more quickly. We've also added training indicators. Hopefully you've started noticing those and have found those helpful. What they do, there are definitions for our training indicators, and what they do is allow you to get a better gauge on which education is going to meet your circumstance. Whether you're billing on a UB04 or you're billing on a 1500, it will let you know that this education is going to cover that, whether it's a new provider or maybe it's clinical. So something to keep in mind to look for when you're looking for sessions to attend. So that is going to end our presentation for today. On behalf of myself, Ashley, and Tom, and the entire provider education team here at WPS, I want to thank you all for taking time out of your day to attend. We're all super busy, and sometimes carving this hour can be a kind of a big ask. So we do appreciate that you find our education valuable enough to take that time. We look forward to your survey comments, and we hope to see you tomorrow in part 2, along with other future events. And make sure that you're including topics in your survey that you'd like to see. With that, I'd like to thank you all. Have a great day. You may now disconnect.